Two interventions I do in a clinic setting is, number one, I never use the word smoking or quit smoking. I always say it's between addiction and tobacco recovery. It's a psychic gain, that is to recover from something rather than quitting smoking, which is a psychic loss. So I use those terms
we use the term treatment all the time. Treatment is almost the way we...
Treating nicotine dependence or recovering from tobacco addiction rather than saying quit smoking, I think is more helpful. And the other intervention technique that I've started to use recently, which I found very effective, is I tell people, never buy your favorite brand. Always buy one that you actually care for. Immediately, the number of cigarettes drops down by 20% compared to another time. So that's my first intervention. I get them back to see the milling progression. But I agree with your point. It is a process over time, and you have to pick up these skills to get good at it. But actually, my question was, one of the things I think is lacking in addiction management, tobacco addiction management, is women's monthly cycle and the PMS. And I've only heard it once years ago, and I think it's what happens to women is the timing of birthday is important to quit on the period, because you've got 3 weeks under your belt before the next one hits. When the next PMS hits, then they avoid triggers more up the dose of patch, make more appointments to get them through that PMS. And the other intervention I do with women who have significant PMS or fighting addiction is I use progesterone. The lack of progesterone is the predominant cause of PMS, and so I use progesterone. But I think, well, I want to know if you're doing that, and if you're not, then maybe we can later talk about the protocol for that. Because I think it is an important part of the team.
Richard, comments?
Well, we don't focus on that too much. We try to focus on their tobacco dependence and withdrawal that they have, realizing that there are a lot of things that can interfere with this, including PMS. So we don't focus to that degree on that you do. There's nothing wrong with that. It's just that actually our patients are probably as a rule a little bit older than that. What the average age would be for certainly our residential patients are older than that. And the rest of the patients are probably a little bit older, but it's an issue that comes up a lot, but it's not unlike other issues that come up a lot with other stressors in life, and we try to help them to deal with those with adding coping skills and doing things through the motivation interviewing technique.
Another quick comment, if I may, is that clinicians like yourself are becoming far more adept at understanding a whole array of processes that interfere with, that are impacted by smoking. I mean, it's been said that if you place a woman on the birth control pill, her rate of nicotine metabolism will double. A woman becomes pregnant, her rate of nicotine metabolism may quadruple or quintuple. And the rapidity with which you metabolize nicotine makes it progressively more difficult to stop smoking. So I congratulate you for what you're doing. I think there's a lot to be learned in these sorts of things. I am going to have to move on because time is really precious, and you've been very patient.
So I was meeting this past Tuesday with the medical director for our continuing care facilities and that, and we have a smoke-free campus policy. And we'd allowed them to continue to offer smoking rooms in some of our continuing care facilities. You know, from the point of view in terms of respect for more of a home-like situation in that. We're now moving to phase those out in terms of the next year and a half. And some of the pushback from the medical director when we were raising this was, well, the average length of stay in our continuing care facilities is only 18 months now. Why are we intervening in terms of with tobacco, you know, short lifespan left? And I'm wondering about insights that you could give to address that. And the other issue that's been pushed back again is within the home care and continuing care is the concept of risk. So they say even for patients that are on food restrictions or dietary restrictions in terms of soft food because of choking hazards and that, that doesn't stop them from eating foods that place them at risk in terms of dying from aspiration. They make that as an individual decision. So any thoughts, guidance in terms of how to engage the physicians and clinicians around that?
Well, first of all, it's a workers' issue as well. I mean, there's no safe level of exposure to smoke, whether it be patients who are smokers or workers around patients who are smoking. And so it becomes an issue of really what's in the best interest of the patient and also what's in the best interest of the people around that patient. So this comes up quite often. It's not usually from the medical director, though. That's a little surprising. But the example I give you was we just did a study in Olmsted County, which we have all the medical records for all the patients, all the people in Olmsted County that have all the diagnoses. And when we went smoke-free as a county, the reduction in heart attacks went down by 50% in the 18 months before and 18 months after. The rates of sudden cardiac death went down equally high. So we know that secondhand smoke is a real serious problem. And now we're beginning to learn that third-hand smoke is also a potential problem for people. So in long-term care facilities, those that are nursing homes or in hospice care, if they're undergoing kind of treatment for whatever their ailments are, smoking makes it worse, regardless of what it is. So people are getting care for their cancer, chemotherapy, radiation therapy are worse as far as the side effects if the person continues to smoke as opposed to stopping smoking. And the outcome of those treatments are worse if the person continues to smoke. There's no medical redeeming feature to smoking, period. It causes harm across the board. I don't know if that helps me or not, but that's kind of the way we approach it.
Do you have any comments on that issue of the risk like again, when people are coming into care situations and that in the end around the risk?
Well, I think the caregiver part of this, it's your responsibility to make the environment as best from a health standpoint as you can possibly do. And there are times when people will do things that are more risky that you can't control. But your obligation as a healthcare provider is to provide the safest environment for that patient as you possibly can. And allowing smoking is certainly not allowing us or providing a safe environment for that patient or for anybody else around that patient. So this thing of choice gets put into play all the time. And the most favorite word of Philip Morris and BAT and Imperial Tobacco is choice. And they do it all the time. It's a matter of choice. What's the big deal? People choose to smoke, they choose not to smoke. There are now more ex-smokers in the United States than there are current smokers. What's the big deal? It's a matter of choice. Well, if you look at the brains of these people, it's not a matter of choice at all. I mean, they have become addicted to a product designed to do that. And so we deal with the choice issue of basically going back to what I just said. We as healthcare providers are obligated to provide the safest environment for the patient as we possibly can do, and that is not included in allowing them to continue to smoke any more than we furnish them a fifth of our liter of scotch every day.
I think our time, regrettably, has come to an end. I know that Richard will be around for the remainder of the day, and you can tell he's got this Kentucky charm, and we'll be delighted to respond to your individual questions. I hope that you've enjoyed this slightly structured but nonetheless conversational opportunity to interact.